demonstrating typical angina symptoms. And the electrocardiography shows the inferior STEMIs with the high lateral reciprocal changes. So after discussing with the patients, he agreed with the emergent coronary angiography. And in this show, and let's view, we can see there is one lemon bifurcations lesions around 111, Medina 111 lesions. And the infarction-related artery is the RCA. So it is one proximal lesion around 70%, and the distal total occlusion of the PLA branches. So this is a patient, we can see the calcium burden is very heavy, and there is a total occlusion. So maybe can we need a rotablation and also a Lehmann disease, Lehmann triple vessel disease, and the patient present with angina. So we discuss with the patient and the family, and they turn down the KBG suggestions. So we perform the emergent PCI for these patients. We're using the left radial artery route as the currently ESC guideline recommendation, and using the short tip AL1 guidance. And luckily, we can passing through the lesion under the warhorse thermal run through wire, and under the support of one small sapphire balloons. And because this is a lesion, is a bifurcation lesion, so we pass another workhorse wire C1 to the PLA branches and perform the POBA first to both branches. And we can see after POBA, the lesion and the total very, very big PLA branch is disappear. So we can see there is because this time we're facing a very big problem because the PDA and the PLA bifurcation branch, heavy calcium burden, and also the bifurcation stenting may be needed, but the vessel size is a small vessel disease, and also one proximal RCA lesions. So after discuss with the patient, the PDA PLA branch is regained, and the patient's hemodynamic and the ST segment is improved. So we just put one stent over the proximal lesions, and this is the final result. The final result is the proximal lesion is very good, and the PDA PLA bifurcation is very good. So the patient is just after 2 days heparinization and 3 days observation, he just came to the outpatient clinics. So at this time, we fixed the RCA lesions, but we left the Lehmann bifurcation lesion. Should we complete revascularization these patients? So this is the complete study from the 2020's PCR courses. And at the complete trial, we can see for the stenosis patients, the complete revascularization, we can reduce the myocardial infarction, CV deaths, and also ischemia-driven revascularizations. So, and the Lehmann disease is a different animal because they have a very, very huge side branch, the second phase, and the LAB. And however, there is a very big divide. Should we treat the provisional stenting or just systemic two-stent strategy? And it's because from Dr. Chen from Nanjing, he also provoked the DK crush techniques for all the Lehmann bifurcation lesions. But there is some debate because some experts suggest provisional stenting is better because the less stent strike is better. So we discuss with the patient, should he or she receive the cabbage for the Lehmann bifurcation lesions or do a PCI, and the patient turned down the cabbage suggestion. So around 1 month later, we just send the patient to the cast room for the Lehmann bifurcations revascularizations. And after 1 month, we can see the stent is very good, and the distal bifurcation lesions, although there is some haziness, but the flow is teeny 2 to 3 flows, and the patient is currently symptom-free. So the lemon lesions, there is very tight lesions for the lemon bifurcations. And we just put two Warhol's wire run through and the Sion to a distal LAD and the distal circumference artery. And first, we do the small balloon, 2.0 balloon, to dilate the lemon to the LAD. Then we check the IVAS. Because for all the lemon bifurcation lesions, we need to provide a better stent outcome. We should choose the image guide strategy. So this is the IVAS from the mid LAD to the lemon. And then we can see there is a plaque burden from the ostium LAD to the distal lemon. And there is at least 180 degrees calcifications. And then we put IVAS from the proximal circle to the lemon again. And the distal circumference size is very small, and the plaque burden is around less than 50%, and there is show lesions. So at this time, we're facing a lemon bifurcation lesion, and there is a true lemon bifurcation lesion. Should we choose the provisional stenting or like the Dr. Chen's go direct, DK crush. And however, when we choose a provisional stenting or systemic two-stent strategy, we have some advantage and disadvantage. Like the provisional stenting is easy and simple. However, we have a risk of side branch occlusion, and the rewiring of the side branch may be more difficult. And also, when the long side branch lesions or difficult side branch access may be using the provisional stenting more not favorable. However, and so we choose the provisional stenting because the lesion of the circle is very short and the circle is not as big because we can see the patient is right coronary artery dominant lesions. So we just put one drug-eluting stent from the proximal LAD to the lemon ostiums and do a post-dilatation, and we check the IVAS from the mid-LAD to the lemon, and we can see the stent opposition and the expansion is very good from the proximal LAD to the lemon. Okay, here is the lemon stent. And the very size, the size is around 4.0. So this is the final angiogram. And very size, because we're using with the side hole, BL 3.5 side hole. Okay, so the take-home messages is complex PCI can be defined in many ways. However, it's related to the procedure risk and the future risk of the ischemia event. We should consider the distribution and the extent of the disease, also the lesion characteristics, patient's comorbidity, and also more important is the hemodynamic status. The outcome is dependent on both types and the number of the complex features. This patient is currently followed in my outpatient clinic more than 3 years. And totally event-free and symptom-free. Thanks for your comment.
Thank you, Dr. Huang. If the audience have any questions, we are going to have some discussion time in the end of the session. Now I'm going to introduce the next speaker, Professor Roman. Professor Roman has diverse expertise in many fields of cardiology, including clinical cardiology, interventional cardiology, and the basic science as well. He has a lot of publications regarding genetics and cardiac physiology. And he's now the professor of cardiology and vascular medicine and Vice Dean of Academic Affairs in Brawijaya University. And he leads many professional societies in Indonesia as well. He's going to talk about improving ACS patient outcomes in developing country. My experience. Let's welcome Professor Roman.
Thank you. Good afternoon, everybody. to our respected colleague, Professor Wang, Professor Ma, and other colleague of Yunlin branch of NUH. Please allow me to just present brief what we do in Malang regarding the improving ATS patient outcome in Malang. As next, please. As we know that actually Malang is the small city located in East Java and in Java Island. Next. We have actually only have four cath lab dedicated hospital which receive the referral patient from the many side of the Puskesmas, public health center. Next, we actually built the networking of HES since 2015. And since then, we actually receive many HES patients for 24 hours, 7 days for primary PCI. Next. This is the our problem phase when I graduate from the Harapan Kita Hospital 2010. I faced many problems regarding the high mortality and morbidity of CVD, reaching 20% of in hospital mortality in case of the HS. That's why actually we like to solve the problem by dissecting many undergoing background of the heart disease regarding the promotion and prevention, and I also performing the molecular genetic, pharmacogenomic, and other polymorphism predisposing to the heart attack. And then we also built the registry of SNAI and also dealing with the delay, how to solve delay. We have many problems here because we don't have EMS system. We have no dedicated ambulance for taking the patient from the peripheral hospital to our center. And then we also facing the awareness of the patient, which is actually almost 5 hours take time for patient come to our hospital, even further delay made by the first medical contact doctor. Next, we also train the cadre and also the general practitioner to increase the knowledge and also the skill how to aware of the HES patient and send in the proper time. And also we dissect the next the problem of heart failure and rehospitalization, comparing the sign and drugs, and also how to optimize the drugs during the hospital stay. And by next, we also build the community of the HES patient and cardiovascular disease patient. From this community, we increase the awareness and also the quality of life. Here, one of the example of the our publication. And next, also we have our own journal, which is many published article already done. And next, also including the how the PCI performing in a high score of syntax score, resulting in still improving of quality of life in CID patient. This is also the pattern of the HES patient present to our hospital. the patient might come directly to the Saiful Anwar Hospital, but still there are some delay reaching to the 4 to 7 hours. And then some patients still try to make decision of self-medication. And sometimes the patient come to the first medical contacts doctor, and all resulting in the more delay and high morbidity and mortality. Next. That's why actually we try to help the provider, first medical contact doctor, by making the course a serial course, and also consultation via WhatsApp application. Next. And also to no, please come back to the yeah. For the increasing the patient awareness, we create the data application, which is actually artificial intelligence based analysis and symptom of patient, which is actually report to the our application, and then from the application the patient guide the hospital. Next. This is kind of the list of the problem we face. Next. And then one by one we troubleshoot, and we did the troubleshooting. And then from mortality of 20% in 2011, by making the many education, and then also regular meeting and upgrading. Next. We finally achieved the goal of the next improving mortality from 20% to the almost 9% of mortality in hospital within 4 hours, 4 years duration. This is actually the data of summary data of the our primary PCR. According to this data, which is actually most our patients come from the our network. Instead of the other patient come, they wish to come to our hospital, and by years of 2020, the referral patient achieving 76%. I mean, this is our effort to get the precise shorten delay by making the networking, not only waiting for the patient in hospital, but we proactively ask the cadre, ask the general practitioner, ask the patient to get faster to the hospital. Next. This is next our history of application development. From 2013, we developed the networking system. Next. And then by this networking, we shorten the delay from the 6 hour to 4 hour, but still delay. And then we hope that by creating the application base in mobile phone, we wish that the patient getting the high awareness, and then resulting in the more delay shortening when reaching to the hospital. Next. Instead of the addition of the ATS program, we also developed this early warning system for the heart failure patient. Next. And elaborate between three applications: data application, heart failure application, and also the arrhythmia detection. We elaborate in one-stop CVD services for the application. Next. This is actually the distribution of our patient. Some come from the Malang, and some come from the outside of Malang. Next. This is a look of our cath lab. We have two cath labs. and then around 500 to 600 years, and then even lower in COVID era, approaching half of the full case of the previous years of PCI. Next. This is baseline characteristics. Next, we can skip. Here we can see that in our population, smoker is a big problem. We have deal with high prevalence of smoker, and then even increasing year by year. And also the other risk factor is hypertension. The second risk factors we face is the highest second risk factor is hypertension, and then diabetes is the third most prevalence of the risk factors. Next. Uh, this is we can skip next. Yeah, this is actually we can know that some patients develop KILIP 4, yes, because of delay, but most of them actually come with KILIP 1. Next. Next. And then this is the angiographic procedure. Next. Yeah. Uh, as we can see here, no, previous slide, please. As we can see here, actually, we mostly perform in femoral access manner, and then we focus on the uh, culprit lesion instead of the complete revascularization. Next. This is actually the proportion of the stenton with predilatation, and sometimes we also performing during the situation of critical, such as we should intubate because of the failure. We also sometimes we use the IBP to support the dynamic. Next, sometimes we also, of course, we put the pacing because of the block of rhythm. Here we can see the response time from the door to crossing wire, and also time from symptom to the hospital arrival, even longer in COVID era. We know because they should underwent the screening first before the procedures. But still, we have some difficulty to shorten the delay intrahospitally because we should discuss with other division, not only in cardiology teams. Next, this is even in hospital. Mostly we can see here the uh, mortality because of cardiac case, as we can mention that from 2000 from 2011, which is reaching 20%, and in 2018, the mortality decreasing to the 9.2%. Even more decrease in 2019, achieving 8.8%. However, in COVID era, we hamper with the procedure of screening, and some delay, also even longer, resulting increasing in hospital mortality of patient underwent the PCI, primary PCI. Next. The arrhythmic complication, as we can see here, the VT may sometimes happen, and then roughly achieving the 15% of AFib blocks, and also atrial fibrillation. Next. This is case distribution. We are actually almost the same case load, except the younger cardiologist intervention. Next. Here we can see 80% of the procedure were stent implantation PCI. Of course, DCA because the patient candidate for the CIBG performing in our hospital starting from 2 years ago. Next. Next. Yeah, this is another feature of the stand implantation years each year, and then trending decreasing because of the COVID pandemic in 2020. Next. This is one of the our journal published regarding the predictor
The number is very large, so the p-value is very, very significant. In another group of patients, this is a patient with 3 vessel disease. We also got the same result. You can see that in compared with the ultracentrifugation, the precipitation method can get more amount of the exosome for further investigation. So we use the precipitation method for our foregoing study. And all of our extracted exosomes are under Western blot for the double checking to make sure the extracted exosomes are present in the extracted particle. We check the antibody specific for the exosome. As I mentioned before, it's a CT9, CT33, and the 81, and the heat sharp protein. This is all specific for the exosome. And then we use a correlation analysis to find that the two methods are highly correlated with each other. So that's our first result. We see that the coronary artery disease is very special and very important for the heart failure in the Asian people. And we find that for the coronary artery disease, the patient with coronary artery disease got more amount of exosome in compared with the patent coronary artery disease. In just by the amount of the exosome, you can make a difference with the two groups without any investigation, just the amount from the coronary artery disease and the amount of the exosome from the patient group. So there may be something in the exosome for the disease. And then we can see another. How about for the diastolic heart failure? Because this topic is just for the heart failure. And it's very hard for all the people all around the world to investigate the diastolic heart failure. So we just use another score system to evaluate diastolic heart failure. All of our patients just be evaluated by the echocardiography. And this score system by our establishment. It's called the Normal Integrated Score System. By calculation of the score, we can divide the patient to be with the heart failure with preserved ejection. That's for the heart failure. And we use our score system to divide, to make a diagnosis of diastolic heart failure, and for the coronary artery disease patient. You can see that in the patient with the coronary artery disease, the patient also with the preserved heart failure, the amount of the exosome are also much larger than the patient without heart failure. So from the difference of the amount, you can find something inside the exosome may be very important for the coronary artery disease or also for the heart failure. And then let's see another group of patients. This is a group with a patent coronary artery disease. You can see that the patient with heart failure also got more amount of the exosome. So the number of the exosome may be very important for the heart failure and the coronary artery disease. So that's our first conclusion. By this study, we make some basic research. We find the more suitable method for extracting the exosome from the plasma. We find that the precipitation method is superior to the ultracentrifugation. Very simple, very easy to operate, and very cheap. And the coronary artery disease patient got more amount of exosome in compared with the patent group. And the heart failure patient also got more amount of exosome. So what we will perform in the next, because the basic research is for the clinical application. So we use this. We wanted to find that we use the next generation sequence to find what's inside of the exosome, especially for the microRNA. By finding specific microRNA, we can find the genetic locus and find the genetic polymorphism. And after that, we will set up the cell model. By mechanical stretching cell model, we can establish the heart failure model. And we can do the drug-to-drug interaction to make clinical application. And so that's our current result from the next generation sequence. From the treating exosome, we compare the patient with the coronary artery disease and without coronary artery disease. We find that some of the genetic locus, especially the microRNA, all of these three are very important or make a difference between these two groups. And the first one is about the atherosclerosis. The second one is about inflammation. And the third one is about genetic locus, maybe linkage discrepancy with the genetic polymorphism. So we are now going further on to find the microRNA and the protein investigation to find the more drug-drug interaction, especially for the anti-inflammation drug. SGLT2 or TTP4 inhibitor, even stenting are undergoing. So that's my presentation. And there's also the hint for the heart failure. We want to find the best research and for more clinical implication. Thank you for your attention.
Thank you so much, doctors. Please stay on the line because we are going to move on to the second topic. The second topic is about improving acute heart failure patients' outcome, the essential role of registry. Will be presented by Dr. Yoga Waranugraha. Dr. Yoga is a lecturer in the Faculty of Medicine, Universitas Brawijaya. He is also an attending cardiologist in our Universitas Brawijaya Teaching Hospital. Dr. Yoga, you may begin your presentation.
Okay, thank you very much, moderator. And good afternoon, ladies and gentlemen. Thank you for joining this webinar. Today, I would like to talk about improving acute heart failure outcomes, the essential role of registry in next 10 minutes. Okay, today I have divided my presentation into four sections. The first, I will talk about the acute heart failure burden, and the second, I would like to talk about the current guideline recommendations, and in the third sections, I will talk about the heart failure registry in Malang that we have done since 2017, and in the last, I will summarize some important message of my presentations. Okay, this is the burden of heart failure worldwide. The prevalence of heart failure is more than 65 million people around the world. And data from the US and Europe recorded that more than 1 million people are suffer from acute heart failure and that need hospitalization in each year, with the total and the acute heart failure itself accounts for 1 to 4% of total hospital admissions. And the problem is the total in hospital mortality of acute heart failure is range from 4 to 7%, with average length of stay between 5 to 10 days. After the patient with acute heart failure discharged from the hospital, the main problem is the high number of 60 to 90 days mortality and rehospitalization. So all of us know that heart failure is a money-consuming disease. It is reported that annually more than 108 billion US dollar is spent for this disease. This is the data from the GAP with the guidelines from USA revealed that the most common precipitating factors for hospital admission for heart failure is respiratory tract infections, arrhythmia, medication non-compliance, diet non-compliance, uncontrolled hypertension, renal failure, and the last is ischemia or AGS. And how about the heart failure in Indonesia? Indonesia has more than 271 million people, and the prevalence about heart failure is about 0.3%, and the total in hospital mortality for heart failure in Indonesia is about 6.5%, and the cost of hospitalization per patient is around 830 US dollars. So this is current guidelines perspective about the heart failure. But before I give a short review about the guideline, I would like to show all of us that almost all acute heart failure patients come to ER with hemodynamic disturbance that includes congestion and also peripheral hypoperfusion. The data shows that the congestion predominates the clinical presentation of acute heart failure. And then all of us know that patients with acute heart failure can be divided into four groups according to the hemodynamic subsets. The first is dry and warm, second wet and warm, the third dry and cold, and the last wet and cold. From this Kaplan-Meier curve, we can see that the patient with a wet and cold profile reveal the higher rate of mortality. So this is nice paper from the Matthew in Journal of American College of Cardiology revealed that the the shorter door-to-diuretic time is associated with reduce in hospital mortality. It means patients with acute heart failure should be treated as soon as possible. The current guideline from SE recommend about in the first 2 hours we have to stabilize the patient and then we have to look for the possible acute precipitator for heart failure such as acute coronary syndrome, hypertension emergency, arrhythmia, acute mechanical complication, or pulmonary embolism. If we find all of them, we have to treat as soon as possible according to the recent guideline. And then, before we give the specific treatment, we have to assess once again the hemodynamic profile because it's very important in the initial treatment of acute heart failure. And then this is, I will show you about the treatment goals of acute heart failure. In the emergency department, ICU of critical care unit or cardiac care unit, we are focused to improve hemodynamic and organ perfusion, restore oxygenation, alleviate symptoms, limit cardiac and renal damage, and prevent thromboembolism and minimize the ICU length of stay. And then in the next phase, in the intermediate phase, in the hospital treatment, we have to find out the specific etiology and also the referent comorbidities. And then we have to titrate the medication, especially the disease-modifying pharmacological therapy should be titrated into optimal dose. And then for the selected patient, we can consider the device therapy such as ICD-CRT or LVAD according to the patient condition. And then after patient has been discharged from the hospital, the problem is how to reduce the early readmission and improve the symptom quality of life and also the survival of the patients. So in the section, I would like to explain about heart failure registry in Malang. Heart failure registry in Malang actually started from 2017. It is a single center registry, but in 2020 we are going to expand from single center to multi-center. Until now, we have collected more than 1,000, I'm sorry, 1,000 and 1,200 acute heart failure patients. And of course, this heart failure registry is an important database for us. The goals of heart failure registry, we can collect a lot of patient sample and then provide the evidence and then improve clinical practice and the last to increase our scientific publication because it's very important for us. So this is the data from acute heart failure registry in Malang. Quite different with the data from the US. The most common cause of heart failure worsening in Malang is ACS, and the second is infection, and the last is, and the third is medical treatment poor compliance. And the hospital mortality rates in our city is still high. It's about 30.6%, with average length of hospital stay is about 6.7 days. Okay, this is our publications from heart failure registry. We have developed the several annual clinical congestion score. Actually, this is the simple score to assess the severity of congestion, it has the maximum score of 10 with a cut-off point of 6. This score has the ability to predict 90 days all-cause mortality with specificity about 66.7% and specificity about 81.2%. And also this score has the ability to predict 90-day heart failure-related hospitalization with sensitivity of 70% and specificity of 85.7%. So you can see in this Kaplan-Meier curve, the patient with cerebral abnormal congestive score less than 6 has a better prognosis that's shown in these figures. They have a lower rate of hospital readmission and also all-cause mortality. And this is our next paper that came from the heart failure registry. We have proved that the optimal dose of ACE inhibitor can significantly reduce in hospital mortality. And the last, maybe this is our recent publications in the Scopus Journal about the aggressive beta blocker titration. In this research, we try to compare aggressive titration beta blocker to guidelines-directed beta blocker titration. Interestingly, the aggressive beta blocker titrations effectively reduce the risk of ventricular arrhythmia during hospitalizations. But in the long-term follow-up, the both groups did not show any significant difference in terms of all-cause mortality and also hospital readmissions. This is the take-home message of my presentation today. We know that acute heart failure is the major cardiovascular problem in Indonesia. Registry provides the big database for us, and the several innovations can be made from the registry data to improve acute heart failure patient outcomes. Before I close my presentation, I would like to introduce all of you. This is the Heart Science Journal. This is the official journal of Brawijaya Cardiovascular Research Center and also Cardiology and Vascular Medicine Department of Brawijaya University. If you have any paper about cardiovascular disease, you can submit to this journal. Thank you very much. Thank you for your attention.
Thank you very much, Dr. Yoga, for your presentations. Now, ladies and gentlemen, we will start our discussions. There are several questions already from the participants. Maybe the first question is to Dr. Chang. The question is from our participants. They said that in your research that you found the connections between exosome and CAD and also heart failure. How can we target this pathogenesis in therapy of patients with coronary artery disease and heart failure? Please, Professor Dr. Chang.
Hello, I'm Dr. Zhang. May I repeat your question? You are wondering about the exosome from the coronary artery disease and from the heart failure, and how can we make difference between them? Is that right?
So the questions for Dr. Chang is how that the research on exosomes can be applied for the therapy of the patients with coronary artery disease or heart failure.
Yes, that's a very important question, and we also discussed that at our labor meeting. So all of our doing is just to find the fundamental theory for the further research and the further treatment in the heart failure. As you can see that in the program or other heart failure trial, we got several very magic drugs, a special SGLT2 inhibitor or something else that you can image from the recent heart failure trial. But what's the real effect of this drug? We have no idea about that. So we have to set up the fundamental theory for that. So we just think about what's the magic effect of this drug. So we think about it and discuss about it. We said that for the drug treatment for the heart failure or for the other drug, especially for the cancer, they also use the exosome for the drug therapy or for the introduce of a drug to the special target of the cell. So we set up the target for the exosome. We want to make it up clear what's the inside of the exosome to interfere with the drug and the drug effect for the treatment of heart failure. Maybe some the drugs are specific for some patient. Maybe a patient are very specific for the genetic point morphin. So we set up the target to find the special target of the exosome and the microRNA and the protein. And then we want to set up the cell-to-cell cell model for further improvement of the drug to make it clear about which the signal pathway are involved in the drug for the treatment of the heart failure. Maybe that can make us clear about which kind of people can use which kind of drug. Maybe this kind of people are suitable for the statin, this kind of people are suitable for the SGLT2 inhibitor, and this kind of drug, these kind of people are for the hypertension drug, maybe SGR, ARB, or something else. So that's the initial our thinking process for setting up this our study design. Thank you.
Well, thank you very much, Dr. Chang, because we know that exosomes, especially on the research on exosome, is a very racing stars now, especially on the ischemic heart disease and also heart failure. We can move on to questions for Dr. Yoga. There are two questions here for Dr. Yoga. The first questions, according to your experience, Dr. Yoga, especially in Malang, what can we do to lower the rate of readmissions for patients with heart failure due to CAD or maybe another etiology? Thank you.
Okay, in Malang, actually, the most common cause of hospitalization for cardiovascular disease, the first is ECS and the second is acute heart failure. So, how to improve the outcomes? So, the first thing we have to follow the guidelines, okay? Because the guidelines give us strict direction, and we know that the guideline is made from acute evidence, so we just follow the guideline. And the second, the most important thing, we have to have our data, because most of data that uh, used to build the guideline is come from Western country, which it means that maybe uh, for the local people is maybe sometimes it's not uh, correct appropriately. So maybe the best way, we have to collect the big data, and then we can make the good analysis about that with the local wisdom to make our uh, data. But the most important thing, follow the guideline. Thank you.
So thank you very much, Dr. Yoga. So we have to follow the exact guidelines and give the patients the optimal therapy to prevent the hospitalizations. The second question is also quite a practical question, Dr. Yoga. Based on your experience for heart failure registry or any type of registry, is it feasible for doctors who are working in smaller district hospital because Malang is a big hospital, also government hospital? Is it possible for doctors who want to start a registry for heart failure, maybe in district hospital or in primary health care?
Okay, I think it's it's possible. It's possible because today we have a lot of many platforms such as Google Sheet or also Google Form as the tools to do the survey. I think by using that platform application, we can get more data. But the most important thing while we collecting data is the consistency, because maintain the consistent work is not easy. Thank you very much.
Okay, so it's possible, and maybe the smaller hospital can work together with
Yeah,
center
of course.
hospital, yes, to make the registry. And Dr. Chang, there is one more questions for you. So the questions from our participant: is there any connections between the exosome, especially on its size, with the severity of the disease, like in CAD or heart failure? So maybe is there connections between the exosomes and the severity of the disease or the progressions of the disease? Thank you, doctor.
That's a very interesting question. We just find the size are not different between these two groups because the size is very small. So we just ignore and compare the size below the 100 nanometer. So there's no difference between the size of each group. Thank you.
Okay, thank you, doctor. Dr. Chang, also Dr. Yoga. I'm so sorry, unfortunately, because of the time limit that we have, I have to conclude our third sessions. From the both presentation, we learned that we can gather a lot of benefits from both research fields and also registry data in the management of heart failure patients. So once again, please big applause for our speakers. Thank you very much for the interesting presentations and the fruitful discussions. Now, ladies and gentlemen, before we end today's webinar, I would like to invite Professor Matthew Ma to deliver the closing remark. Ladies and gentlemen, please welcome Professor Matthew Ma.
Good afternoon, ladies and gentlemen, both in Yunlin and also in Milan. Long time no see. I would like to thank the organizers from both universities for making this webinar such a very successful one. I believe participants in Milan as well as Yunlin would agree with me this is indeed a very stimulating and very insightful webinar. So we have speakers and experts from both universities elaborated on the state-of-the-art science and some of the local perspective and local innovations on three major areas in cardiology, namely arrhythmia, heart failure, and coronary interventions. And as this webinar has demonstrated, the depth and the scope of the practice and research from both of our university are truly remarkable. And this also indicated the future possibilities for our deepened collaborations in both clinical exchanges and collaborated research. And as we know, we already did that when Dr. Yoga was in Taiwan. He was very eager in conducting research, bringing together the expertise between Brawijaya and NTU. I would also like to thank our superintendent Juan, Professor Juan, and also Professor Cypher Roman from Brawijaya for your support in this bilateral collaboration amid this heightened pandemic period in both of our countries. Again, thank you for participating this very interesting and insightful webinar, and we'll be organizing future webinars between our universities in cardiology as well as in other areas of medical expertise. Thank you again. Good afternoon. Thank you.
Thank you very much, professors. Now I would like to invite the Vice Dean for Academic Affairs of Faculty of Medicine, Universitas Brawijaya, Professor Dr. Muhammad Saifur Rahman, to deliver his closing remark.
Yeah, thank you, Dr. Putri. Hello, Dr. Prof. Ma. Also, Prof. Wang. Here I talk in terms of the collaboration our two side. Please maybe we can extend to the other activities like Prof. Ma uh, deliver just today. We hope also actually many programs we can perform not only in field of the cardiology but maybe one or two of the field such as respiratory medicine and also the rehabilitation uh, of the Brawijaya University like to discuss further more about the opportunity, possibility to performing the exchange of the staff or other activity. Hopefully, within the next future, we can discuss further to the extends our wisdom to deeply and further elaborate not only the webinar but hopefully also in research publication, joint publication between two sides. Thank you so much for your kind attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Professor Dr. M. Saifur Rahman. Well, ladies and gentlemen, unfortunately, we have arrived to our end of this webinar. Once again, on the behalf of the organizing committee, we would like to thank our distinguished speakers, our distinguished moderators, our colleagues from the National Taiwan University Yunlin branch, and to all of our participants for making time in your busy schedule to join us here in this afternoon. I wish you all the pleasant day. May this webinar bring benefits for all of us. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Thank you. See you.
Bye bye. Ciao.
Terima kasih semuanya, Dr. Farida, Dr. Putri.
Ya, makasih. Wes, close.
KPS. Terima kasih. Monggo, silakan. Foto sih. Foto untuk anu nih, akreditasi nih. Bukan bukan klinis kalau ini kan akreditasi. Oh, model Mas Indra itu. Oh, profilnya seperti itu ya. Gimana, Bro? Ya di sini situ. Ayo berdiri semuanya minta tolong untuk KPS ini, untuk akreditasi. Ayo. Tahun berapa ya? 2015. 2025 KPS udah bantu. Seumur hidup.
Nih, nah, itu
Sekolah, di sini sekolah, Bu. Berdiri atau duduk? Maksudnya? Fotonya. Berdiri loh, gak cuy. Kelihatan, kelihatan ya? Social distancing. Distancing, beres. Ayo beres. Kalian dulu. Udah, Pak KPS ini, Pak KPS. Bro, silakan, Bro. Ayo berdiri sini. Berdiri di belakang. Ayo berdiri di belakang. Ayo Halina, ayo berempat. Sini sini Putri. Berlima enggak apa-apa. Di depan aja, di depan. Yang PPDS di belakang di situ. Ya, ya. Ayo, ayo. Ininya di anu ya, dicampain. Yo 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 yo. 1,5 meter. Ya. Terima kasih. Nanti disimpan ya, jangan dihilangin itu untuk akreditasi itu.